Okay, I have 5:02, so we will go ahead and get started here, I think. Make sure I have everything working here. Okay. Thanks for joining. As usual, please feel free to interrupt or stop me, or one of my colleagues here can tell me that there's a question if there's a question, and we can kind of go from there. So I'm Matthew Goodwin. I'm at Washington University in St. Louis. I do mainly spinal tumors. The thought for today, I would just go through a few of the recent cases we've had. I think last time we presented, we talked a lot about, or went through some of our custom implants that we've used, kind of the custom 3D printed implants we've used. I shied away from that today and just tried to pick out some of the things we've done in the last couple of months. For the most part, these are from the last couple of weeks, I think. Hopefully there's some good stuff to talk about, or at least kind of go through some of the things we think about when we approach these, and we'll kind of go from there. Here are my disclosures. Nothing directly related to today. So some of this is a little bit of review to start, but spinal tumors, we're going to talk about primary tumors, and then we're going to talk about metastatic disease. We're at our place here pretty busy with both of these, and I think we have a pretty good setup and pretty good bandwidth to handle it. We have a lot of patients here with disease, and thankfully we have a large team as well. So I want to start by just showing this slide. I just made this slide today, but I feel like I'm always expanding this slide, and I think the first thing to say is that it's absolutely a team approach when you tackle spinal tumors. And so I'm just showing you kind of several of the people involved on that team here. We have our spine tumor board every Monday before the OR, and every Monday we go through a lot of patients. And if we have a multi-team case coming up, some of the lumbosacral cases, some of the chest wall cases, then we'll typically have a planning meeting separate from that for those cases. So we might have a Zoom meeting at night in the weeks leading up to it, not only for planning, but sometimes we're not even sure exactly what should be done or what the right thing is. So I think one of the things that we've had here that we've been very blessed to have is mutual respect between providers. And that's something I don't know that is always the case, but certainly is the case here. And I'm certainly grateful to my teammates, so to speak, for that, because they all bring something slightly different to the table when we approach these. I think another thing we do here that a lot of places do as well, which is good, is we have ortho and neuro operate together. So in the upper right, you see Camila Molina, my neurosurgery partner here. And we do pretty much every tumor case together. And that's something that I've known Camila for many years now, dating back to training in Baltimore, and that's actually been fantastic because he brings a different skill set, he brings a different thought process, although not that different because we train together some, but certainly having two sets of attending experienced hands doing these makes a big difference, not only in the case but in the workflow of the day and the time it takes. And then I've shown here lots of different people. So our department chair, Regis O'Keefe, who's also an ortho-oncologist. I've shown some of our colleagues from various departments. We won't go through them all. Some of our oncologists, our flap team, and here's my nurse, Angela, and I have to put her here because she takes care of all the spine tumor patients, and she works endlessly to make sure every test is done and make sure if there's something going on that I know about it, or if I don't need to know about it, that I don't know about it, and whoever needs to know about it knows about it. So that's a big deal. And then I've included the residents here because the residents have to buy in a little bit as well. Some of these cases can be very long, very hard, and as many of you know, it's hard if the resident doesn't have an interest in tumor, doesn't have an interest in spine, and I think at the end of the day, we have a great group of residents who have an interest in caring for patients, and I think that goes a long way in these cases. So you can classify spinal tumors lots of different ways, obviously. You can classify them based on where they are, whether they're inside the dura or outside the dura. And then if they're in the dura, whether they're in the spinal cord intramedullary or extramedullary, outside the spinal cord. You can, go through the various things that are in those places that are most common that can help you as you're working some of these up. You can also think about the age of the patient. That's another way to classify these. So thinking about what's most common in different age groups. Like some of the things shown here in adults, you're always thinking mets myeloma lymphoma before you think anything else. And then you can think about location in the bone. And so there are certainly things that are more common in the posterior elements of the bone, certainly things that are more common to be found in the vertebral body. That being said, not everything always follows the rule, as many of you are well aware. It is helpful to have the big picture in your mind when you're approaching these cases. And so certainly I think the way we teach it here is when you're working up a lesion, be familiar with what some of the classic imaging looks like. And so, for example, tumors are oftentimes disc-sparing processes. So if you're looking at case B here on the bottom, that CT scan and that MRI, this is a process that's starting in the bone, appears to be sparing the disc above and below it. And if you look above there at case A, this looks like something that started in the disc space, has eroded into the bone. And so A would be more common to be your typical infection. B would be more common to be some type of tumor. Atypical infections, TB, fungus, brucellosis, act differently. They may actually be disc sparing as well. And so here's just one example of a process that ate into the bone, but not into the disc, and ultimately ended up being a fungal infection. So be aware of those as well. Obviously, it matters because the treatment for all these is very, very different, right? So for the fungus, it's a washout, doesn't even need any instrumentation in this case. In the typical infection, this is someone who has a deformity, needs some correction, needs a good debridement and correction. And in the primary tumor, as we're going to talk about, this is a patient who's a great candidate for an en bloc spondylectomy, or removing the whole bone with the tumor without opening it, touching it, without contaminating anything, without spilling tumor. Very, very different surgeries. Workup of the unknown lesion is obviously important. This is something we talk about most talks, something we talk about every day here when there's a new consult. We wrote a paper on this, kind of summarizing a lot of what we're talking about today. I published this last year. But here are the components, obviously, the history and physical. You do want to get an MRI of the entire spine, so you can look for skip lesions. You do want a CT of the chest, abdomen, and pelvis for staging purposes. You can see your basic labs here that you can get pretty much right away in most patients. I think getting a plain film and a CT of the area of interest of the spine is very useful and should be done. Obviously, those may not be upright films if the patient can't stand upright. In that case, I think it's still worth getting a supine film, or getting some film. And one of the reasons for that, there's a lot of reasons. One of the reasons for that is so when you're, if you're going to the OR, you have something to compare your localizing image to, especially if it's not clear, they have bad bone. You might get some of the other studies, PSA, other specific things, and we can talk more about those moving forward. Oh, I'm sorry. I saw the chat was active, but they're AI assistants. Okay, so we'll keep going. And then the 2 points here at the bottom, getting a biopsy and having a multidisciplinary team, I think are by far the most important things here. Certainly moving forward without tissue is done in some cases, but not often, and it's for very specific reasons. You certainly want to have tissue to know what you're dealing with, and you want to have a team. The days of doing this alone are gone, and certainly having smart people around you is gonna help quite a bit. One thing that always comes up is the timing of these cases, and we're not gonna, sometimes we take whole lectures on the timing and go through these cases, but we'll just mention it briefly today. The timing when there's cord compression is always a concern, and it's always a concern because you don't want to miss your opportunity to help somebody get better, particularly if they're having neurologic decline. The flip side of that is you don't want to rush in and do something to somebody, decompress them, get into the tumor when that was a tumor that should have had an en bloc or really needed to come out in one piece and not be opened up. And so it can be difficult to decide on when surgery is taking place once you think that a surgery is needed. So these are 3 different patients here in A, B, and C. In A is a patient who had this lesion incidentally discovered on some imaging and was asymptomatic. I'm not showing you the CT here, but it was well corticated, clearly a slow growing process. And she got the rest of her workup outpatient and had a successful surgery a few weeks later. Case B is a patient with metastatic disease who was myelopathic, but it was right before Christmas, and his request was that he go home for Christmas and come back and have surgery after Christmas. And his disease had been stable for several weeks, and so we actually did allow him to do that, and he didn't have any changes. And C is a patient who's had neurologic changes over the last 12 hours. So walking 12 hours ago, now to the point where their legs aren't working. And so all of these we treat very differently in terms of the timing, right? And C, this is a patient who you're likely going to the operating room as soon as you safely can. So you're always considering whether it's a primary tumor or not when you're thinking about this. You're thinking about the timing and what needs to be done. And one of the things that my partner, Dr. Bahovsky, taught me when I started was to think about whether they're even a candidate for an en bloc. I remember we had a few consults early on in my career here where I was kind of sweating it out over an unknown lesion and some neurologic deterioration, but hard to say exactly how much and how fast. And I still remember him teaching me, like, well, is this even a candidate for an en bloc? And several times they're not, right? They're either too fragile, or they're very old, or you look at the tumor and it's already clearly not in the capsule and there's epidural spread. And so don't forget to consider whether this patient could have an en bloc if they were to need it. This is a flow chart from that same article that I think is fairly useful when you're working up the new lesion. And so this is in the yellow journal from last year. And so starting with a new spinal lesion and working through whether they're decompensating. And most of the things we've talked about are here in terms of when you get to work up and when you do other things. Remember, if you're going to give steroids, you typically want to get your biopsy first if you can, particularly if you suspect this could be a lymphoma. All right, so spinal tumors. Again, primary tumors and metastatic tumors. Primary tumors, the goal is an en bloc resection with negative margins, right? So the goal of this is is curative in nature, to get the tumor out and for them not to have recurrence. And that can be very, very challenging, as many of you know. Metastatic tumors, the 2 indications for surgery, spinal cord nerve root compression or instability. And you could certainly put some other things in there and say, well, intractable pain, other things. Typically, those other things fall under one of those 2 things. How do we classify tumors? Well, there's lots of ways you can classify them. We don't always use all of these ways, but they probably all have a little bit useful in them. And so here you see some different classification systems. At the top, you see the Enneking system for primary tumors, both benign and malignant. I can't say that we typically talk about this on the day-to-day. I think it is still tested some. I think it's useful pointing out that in the primary benign tumors, the primary benign aggressive tumors are still tumors that might need an en bloc resection. And so there's obviously some debate about that, but certainly they're typically locally destructive and can need more surgery than a typically benign process might need. And so, for example, here you see different tumor types and the recommendation on the right for the resection. So many of these primary tumors that we're familiar with, an en bloc resection, if you can, is the way to approach it. Some of these benign aggressive things, ABCs, giant cell tumors, if you can get an en bloc resection, there's some decent evidence that might be better, but it has to be weighed against the fact that an en bloc resection can have some side effects, some big side effects, depending on what you're doing and where you are. And then, of course, more of the benign things can have intralesional resections, as you're well aware. All right, almost to the cases here. So, SINS, the spinal instability neoplastic score, is something everyone should be familiar with. It's one of the few scoring systems, I think, that so far really held, stood up to the test of time in terms of its usefulness and how much we refer to it. This was designed for non-spine surgeons to know when to refer to a spine surgeon, and you get scored based on these 6 categories here: alignment, posterolateral involvement, pain, location, vertebral collapse, and lesion quality. And then you add all that up and can determine whether this is likely unstable, likely stable, or somewhere in between. Someone in the audience now is thinking, yeah, most of these are somewhere in between. I think that's true. A lot of these are somewhere in between. Nonetheless, I do think it's useful calculating this because it helps even trainees kind of get in their mind how unstable they think something may or may not be. Last slide before we go through a few cases. I think all treatment of metastatic tumors in the spine are thought about in the context of the NOMS framework. Whether you call it the NOMS framework or whether you don't call it anything, these are the big pillars of stuff most people are going to go through in working these up. And so in this case, N refers to the neurologic. Is there compression of the spinal cord or nerve roots? Oncologic refers mostly to whether something's radiosensitive or not, and how radiosensitive and what radiation they've had. Mechanical, it refers to mechanical stability, so SINS. And then systemic is all the other systemic factors. Could they tolerate a surgery? How risky would it be? What's their prognosis moving forward? All right, so we'll go through a few cases and talk about some of the things we think about here. So first case, 44-year-old female. She has this lesion seen here at T12L1, goes through a workup, CT, chest and pelvis is negative. She gets a whole spine MR done, it's negative. Basically, all her other studies are negative, except for this primary lesion. Labs are unremarkable, and biopsy comes back as a primary tumor. So it's a solitary fibrous tumor in this case. And we've talked to oncology about options and what to do from here. So I hesitate to get into the nitty-gritty of every tumor we talk about, because I am a big believer in having smart friends and talking to the oncologist about treatment and treatment plans and options, and talking to the other providers. In this case, doing an en bloc resection for solitary fibrous tumor, especially a young patient with no comorbidities, they're going to do much better than doing a subtotal gross total resection of this tumor. So she's indicated for an en bloc resection. This is actually from my colleague, Dr. Patterson, one of our chest surgeons here. And you can see here, this is one thing we've started doing really only in the last, I guess, year or so, which is we have a group that now will do 3D printing of our tumors. And we've now gotten in the habit of printing every tumor that we're going to operate on, every primary tumor. And I think at first I was, I don't want to say that I was skeptical, but I certainly, have grown up not training by looking at these, just by using scans. But I will tell you, when we started this, one of the nice things about doing this is it helps communication in the operating room. Now, this one got dropped literally by the nurse. Unfortunately, as soon as I set it down, she picked it up and dropped it and broke it. Nonetheless, it was still helpful. And it's helpful for when other teams come in, or when you're talking, for example, in this case, to the chest surgeon about the nerve roots and where they go and what needs to be sacrificed and what rib, because you might have a slightly different language, or you might talk about things a little differently. And so that's one part that I have found very helpful, is to have it up next to the table, and as you're discussing it, kind of referring to it and where we think our cuts can be. So in this case, you can see to get an en-bloc resection is not going to be super easy, because we're wanting to come through the side of this T12 bone, and making that cut is going to be pretty difficult with the spinal cord there. And so that is what we did here. You can see the specimen. Sorry, I don't have a better resolution picture there. You can see our post-operative CT here. Any screw outside of, any screw we put in, you're going to see in all these cases, we like to be really long. We like to have as good a fixation as possible. And we left the OR happy, and this came back with negative margins, so high fives. But in the hospital, we got x-rays, and it looked like this. And I thought, I don't love that. So I looked at that image and said, well, I don't know, they stitched this together. Maybe she's really not leaning like that. Surely it's not that I didn't put enough fixation here. And so, I sent her back to get another film, and complained, and said, well, maybe it's because they get a thoracolumbar film. But, eventually I got in the room with her and had her stand, and I noticed she stood straight when she held herself in her walker. And then if she let up a little, she would slump over that left side. And this is probably some combination of things, right? One of them is we took 2 of her nerve roots here, and so certainly her body wall in that area is going to be weaker. We took a lot of the bone, so we destabilized her, and then we probably didn't put enough fixation below it here like we should have. And so, one of the things that comes up in the tumor population is patients having these pseudo hernias, right? So they have this bulging of the abdominal wall that is typically related to you taking a nerve root. Here, these are pseudo hernias for different reasons in the literature. This is one of the writes from XLIF. But it's something to be aware of, because we don't think much of it, I think, and patients will complain of some bulging, and a couple of them will say it's uncomfortable. So certainly something to think about. This patient, we took her back and stabilized her, went down 2 more levels, and then you can see, where our resection was. I put in a big allograft femur in the back, and that gets tied down. You can see it's here to the bone, and she did much better and was much happier. These allograft struts that we sometimes put in the back, I think when I started, and even still, we sometimes talk about them as maybe not doing much. We put them in sometimes as another piece of support, particularly early on. But one of the things we've seen here is a lot of these actually go on to fuse. And so we're still looking at it and actually writing a paper about it. But I mean, this is a patient who had a primary tumor from, I think, 4 years ago now, and had a similar thing and went on to fuse her strut in the back solidly. You can see here it's well incorporated. This is a patient with myeloma who I remember doing the case and putting this in, and one of my colleagues saying, well, that's not going to do anything. And she went on to fuse and has done great. So we've somehow seen a lot of these allograft struts incorporate into the bone and last for a long time. And so probably need to study a little harder than we have so far, but certainly seems to be a useful thing that can be done with these patients. Oftentimes we're thinking about putting in a vascular graft if it's a primary tumor. That's probably the best answer. But there are times when, if it's a primary tumor and it's a long case, there are times when you're worried about the time on the table and how much it would add to do that vascular graft. So more primary tumors. This is one that I think most of us enjoy getting. So 83-year-old female with a sacral mass gets biopsied, and it's a chordoma. What are you going to do treatment-wise? We can spend the hour talking about this case probably, just from a academic standpoint and treatment options. At the end of the day, I encourage her to see lots of people and talk about it. Very smart, 83-year-old, very fit. You would think she's 53. And so, the chance of her living for 15 years, is not actually that small. She has really no other comorbidities. And so ultimately we elected to take this thing out. And so here you can see some of our preoperative planning again. And so we're looking at the sacral roots here. And you can see in the model that we've had made, blue is the rectum here, and red is the tumor. And again, this was, even though we've gone through these images a million times, we measure them like we always have in years past. Even in the operating room, I have to say it was helpful when we were, cutting down here, saying, well, we can actually bring this down as long as we stay lateral to the edge here, because we're staring at the model, we know the tumor's here. And so it was actually, again, very useful as we talked about what we were doing when we were there. We always go through our CT sacral tunnels preoperatively and compare it to the X-ray because we know when we get in there, we don't want to be at the wrong level, and we want to make sure our localizing images take us to the right spot. And in her case, she has these other Tarlov cysts here, and so in a lot of these cases, we'll actually expose at S1. At 5-1, we'll do a little mini lammy. That way we can do a lammy down the sacrum, follow the roots down, and then make our cut. In this case, we didn't really want to do that because the dura was so thin here, it actually had eroded through the bone. Our preference was, why don't we expose down here and try to leave this alone. So we really wanted to make sure we had the right level in this case. And so that's us here checking the level intraoperatively. And then you can see where we cut right at S3, and here's an X-ray of our specimen after taking it and a picture of it, and you can see the tumors remained well encapsulated in taking it out here. Of course, they're not always that small, and so the small ones are nice because you feel good about getting that margin you need. And it's a big deal that what nerves you take, right? And so we're always trying to save S3 nerve roots if we can for the bowel and bladder function. Here's a 48-year-old who has a sacral mass, and it's a chordoma. Workup's clean, but it's much, much, much bigger. And so it's I've just shown you a few cuts here, but it's almost fungating out of the skin midline. It wraps all the way around to the edge of her greater trochanter. And this is going to be a little more challenging. And so she also is indicated for an en bloc. There was some discussion about whether we get it all or not. And it certainly made surgery challenging. But again, we have fantastic colleagues, and we did this, Camila and I, with Ian English, one of our orthopedic oncologists, who really led the charge around the tissue on this side, which helped a tremendous amount. And so here's the tumor. We were able to get it out en bloc. You can see again where we made our cuts. And maybe I shouldn't have included these. I would not advise X-ray your hands, but it looks like somebody was holding this when they X-rayed it. But here you can see the sacrum and the big tail of chordoma. Again, sacrum and the big tail that came out. And here's just the post MRI where this thing has been removed. So, I mentioned the roots, and again, the S3 nerve root is a big deal, as a lot of you know. So, if you can retain one of the S3 nerve roots, most patients are going to remain continent to bowel and bladder. So, this is something we talk about at length in clinic and preoperatively. If we can retain one S3, most patients, not all, can remain continent. Certainly and so what is most? Most is over 50%, kind of depends on who you read. Everybody's gonna be a little different. We really don't know until we've done it where someone's gonna land on this. So we certainly know that sacrificing one of the S2s is gonna lead to bowel bladder sexual dysfunction in most people. And so in the middle there is that gray zone. And so we always talk to patients about that, keeping both the S3s those patients typically are going to have bowel and bladder function, but they might have changes in sexual function. They might have changes in sensation. And I tell all of them that. I tell them all, expect to be different. How different things are, we're not going to know. And we're going to take what we think we need to take to do the right surgery. And so, we had a case recently where we felt like we had to take one of the S1s because it was going down into this entangled mass of tumor. And remarkably, that patient still, had some preserved plantar flexion on that side. And so it's always variable what you're going to get out of some of these, but certainly it's something you want to talk to the patients about beforehand before you get in there. Sometimes there are places where, it's you can't take such a big piece of tissue when you take it out. And so here's a case we did last week, I guess. 48-year-old male has this lesion starting from T1. And you can see it really encompasses C7 to T2, right? It's got this tail going up in front of C7. You can see it's from one bone, goes down into T2. I've kind of covered it up because I didn't do a good job of putting these slides together. Here you go. You can see it here. Here it is on the side of T2. You can see T1. So this is clearly going to be a problem, going to be a challenge. Comes back as chordoma, no other lesion, young, healthy person. So again, this is a patient who would be indicated for an en bloc procedure, but it's going to be hard. This is going to be a difficult surgery. And so, you certainly talk to the patient about how we're going to do it. In this case, we went and this was Dr. Molina's patient, actually. He went in the front and I joined him the first day to basically try to isolate this tumor and to divide the disc space above it. And we didn't advance here. And then here we are on the second day where we've come back in the back. And you can see this is our 3D model. And you can see this is the tumor that we've now removed en bloc. And it was hard, right? Because you have to rotate this thing out around the spinal cord. You're trying not to spill the tumor, and you're trying not to disturb the spinal cord, right? So we have our temporary rod in. You don't want to stretch the spinal cord. To orient you, I flipped this, and so the head is north and the tail is south. And so you can see this root here is your C8 nerve root. And this is your T1 that's been tied off. And so in this case, we wanted to preserve this, even though it was really draped on top of the tumor. The tumor has been removed, and give this guy some chance of reasonable hand function. The T1, as you can see on some of these images, there was no hope. It went directly into the tumor. But the C8 root we were able to save on both sides, which we were happy about. And so again, we went in and were able to remove it en bloc. We were able to do it without spilling it and rotate it out. But again, if you're doing these, if you're doing them, you should have done them, right? You in training or wherever you got taught. But it's a little bit of a dance with you and your partner. One's keeping the tumor away from the cord, the other is rotating. You're both kind of rotating to get that thing out. What can happen, and what I've seen happen, is that thing can ding the spinal cord. So you got to be pretty careful when you're doing this. In this case, you can see we've used multiple rods. We've put a big cage in the front and used a big strut in the back as well. And this patient's done really well, right? This patient has actually has sensation in his hand and has interosseous is weak and grips weak right now. So switching gears a little bit, probably a little less sexy with these cases, but interesting nonetheless, I think. So this is a 51-year-old gentleman who comes in. He's had this disc arthroplasty a couple years ago. He actually came from a colleague in town who said, I am not sure what is going on here, but it doesn't look good. And he's got this destructive lesion at 5'6", where you can see they've totally collapsed, and he's developed myelopathy. So if you look and you look at the posterior elements of this, so here's 2, 3, 4, 5. Right, here's the posterior elements of 5. So 5 and 6 are both collapsed in this little space here. The arthroplasty was at 6, 7. So pretty big collapse there. This gets biopsied, comes back as plasmacytoma, and this patient underwent a pre-op embolization in preparation for surgery, but they were unable to embolize anything. And so Myelomatous lesions can be very bloody intra-op and can be very difficult to deal with. And so we were not very excited about that. And so in this case, I elected to go posterior first, which is probably a little unusual. But I had two things. One, I was worried about how collapsed this was here. And I was worried about finding a way to distract this correctly, finding good bone above, dealing with the arthroplasty that was in the way, and dealing with the bleeding, and dealing with the cord that was being compressed. So I didn't love all of that together. And so I thought, well, I had him do some flex X. He got some extension, and he didn't have any symptoms when he did it. That's one of the things I talked to him about. And so I actually took him to the operating room and extended him, and then decompressed him and stabilized him in that position. So you can see here, I got a lot of length back, and it came, this was not. We didn't have to work very hard to do this. He kind of just drifted right back to where he was previously. So we went posterior first. We locked him in. We decompressed him at that level, and then we came back a day or two later to do the front part. And our life was much easier on the front because it was already held out the length, and we were able to get the tumor out, control the bleeding, free up the cord, and get our cage in place. And he's gone on to do very well moving forward. Here's a different case. This is a case from a year ago. I just put it in here because I don't think we've talked about it at this conference. It's a patient who's a physician, and she came to clinic 2 months out after having surgery that you see here in another country, and no other lesions, and didn't have a biopsy previously. So she developed back pain when she was in this country. They did a scan and saw a lesion, and took her for a subtotal decompression, put in a cage, and it came back as a primary leiomyosarcoma. So this is a bad situation. She presents to us here with terrible back pain, can't stand up, feels incredibly unstable, incredibly painful. Obviously a tough situation. This was the original image that we were able to track down. Which is unfortunate because this should have been worked up appropriately. So what do we do now? We got some scans and looked at where the tumor was. There was no sites of distal disease. It was all contained around this cage. If you look in the bottom right there, you can see that she probably has good reason for having intractable back pain. The bone all around the cage was getting pretty destroyed, and that thing was even kind of subsiding sideways in there. So we talked at length, and she was a physician, very smart, and I basically told her we can probably do an en bloc, but it would be heroic, and it might not be that good, but we can give you one shot to really get a big margin around whatever's there. And in the process, stabilize your spine, because as it was, she was going to need us to stabilize her spine anyway. And so that's what she wanted to do. So we did posterior first, and then came back and did the en bloc and took everything out. And so that's essentially the area we were addressing. And so here's stage one. We got around her spinal cord and placed this elastic sheath, put in our instrumentation, used a big femoral graft, femoral graft in the back, multiple rods, and then we scanned her after we did that, anticipating we were coming back, or anticipating that the next stage, just to look at where everything was, make sure we liked it. And it was actually Melina who said, "Hey, I think this is a little more eaten away than it was." And sure enough, when we look back at our old scans, this was even a month ago, this was a new area up at the top here where it looked like more was eaten away. And so we were planning on our en bloc, and we said, gosh, I don't like that at all. And so, what do we do now? Well, we got an MRI, and we actually had we had a Saturday night Zoom meeting with Jack Jennings, our radiologist, to go over some of this. And we said, gosh, this looks bad. And we were looking at what enhances and what doesn't and what to do. And ultimately, we did a Lammy to look to see if there's anything obvious there. We took her up another level to stabilize her. Didn't see anything obvious and told her, look, we should probably still proceed, but with the caveat that I'm not sure it's all coming out. I think this enhancement's probably real. There's probably going to be cells left behind. And so stage 2, we came back, and you can see we took this out on block, even to the point where the cage stayed inside. We even left that screw in because that was in a spot where it looked like there was tumor right there. So it all came out. We reconstructed her with the largest cage we had, and she went on to get treatment for the residual disease that was in there. So she did have residual disease around that area that we thought, but she was ambulatory. I think this is 9 months out here, and with a spine that remained stable, and thankfully this gigantic cage hasn't ever moved anywhere. It's stayed put. All right, so those are some primary disease. Metastatic disease, we obviously think about a little differently. And there's lots of different things that can come up in metastatic disease. So here's a young woman, comes in, hasn't been able to move her legs for over a month now, has been lying in bed, unfortunately. And she has this image with this L1 collapse. She also has a breast mass, and she has other lesions in her spine. Not terrible, but other smaller lesions in her spine, clearly metastatic disease. So in this case, difficult situation. I certainly lay a lot of crepe and say, look, if you haven't moved your legs in a month, I'm not sure you're moving your legs moving forward. And but that being said, she's not, treatment naive, is going to want to be able to transfer. I mean, there's a lot that needs to be done here just in the way of stability as it is. So certainly indicated to have a procedure done to stabilize her. In this case, her bone above and below the level looks pretty good. You can see on that CT there, she doesn't really have any disease in the bone above or below, which we're always looking at. And she does need some correction here. So she was taken to the operating room, and we used an expandable cage in this case, which I'm always hesitant to, because I'm always worried that the bone around it will erode and that cage is going to be floating. And we did it on the pro-axis. So we always use the pro-axis a lot because it helps us with alignment by moving the patient. And so she actually did really well moving forward, and remarkably got her legs 100% back, which her and her family like to tell me I told her that wouldn't happen. So she did really fantastic with this. That being said, there are many times when I don't want to use a cage in these metastatic cases. And so here's a patient not that different, but different in some key ways. So 46, does have known metastatic disease, had radiation to this L3 level, is able to prop herself up, but with terrible pain, and then goes right back down. And you can see here on this film, you're actually looking at L2 here, and you're looking at it sitting on top of L4. And when you look at her skin, she's got these really bad radiation changes to her skin, which the plastic surgery team is not excited about when I talk to them. It says intact, her legs wiggle. She can move her feet. She's just so clearly so unstable here. And so here's her imaging. I think that the most notable thing besides the obvious is the fact that she's got lesions throughout her spine. And she had lots of lesions throughout her spine. And that makes life a lot more difficult, figuring out where you're going to go, where you're going to stop, where you're going to use a screw, where do you need cement, especially in a case like this where the whole spine is subluxated. Here's a better picture just showing the lesions throughout her spine and the difficult job. And then if you look at her pelvis, she's also got these huge lesions on one side of her pelvis that are unfortunate. So your ability to anchor her down low is also going to be compromised. We did talk about no surgery in this case. She has failed some therapy, but people were pretty optimistic that she still had several therapies left that she could go through. And at the end of the day, I felt like she needed to be stabilized anyway, and we did have the means to do that. So this is a patient who I'd say I would not use a cage in, or I'd really try not to use anything like that, because I think the bone's going to probably still continue to get eaten away. And so we went from T11 to her pelvis. We reduced her spine. We got her decompressed. We did use cement at a couple of different levels. If you're using cement to prevent pullout, which is what it's probably best for, you don't need that much, right? You need maybe half a cc. And so there is some risk with using cement. Every time you push it into a bone, you're by definition pushing a little fat out into the blood. And so there's always some risk even of just embolizing stuff. So we're doing it under fluoro. We're talking to our anesthesiologist during it, and we're going slow and watching it. So in this case, we were able to get her back in alignment, and you can see we just put in one pelvic bolt because she really didn't have bone on the other side. She had tumor, and she did really well. She did have one of those fragments where it was subluxated, was actually into her dura, and so we pulled it out and repaired it. And unfortunately, about 3 weeks out, if we have a drain we don't want on suction, we use a bio bag, so no one will put it on suction. But unfortunately, she went to another ED where they pulled it off, put it on suction, and sucked. And so she got massive headaches and had a big CSF problem. Ended up getting a lumbar drain and ultimately did really well. She's almost a year out now, ambulatory, still in treatment and still intact. And so that standing film is her now, 10 months out, still doing well. Might be our last one, maybe our next to last one. So here's a 67-year-old gentleman. He's got a renal cell, has this L2 burst, and really, I'd say a very similar situation. Can't really ambulate, can't do a whole lot. And I think one of my colleagues had seen the patient and was talking about a lateral, because really that L2 was gone, like you can see in the CT. And as they talked to me, kind of handed it over to me and said, "You want to help take care of this?" This patient was fairly fragile, and had been through several rounds of treatment, had pretty widespread disease. And we sent them to get embolized, and they were able to see the tumor, which it was incredibly vascular, as you would expect with a renal cell. They were not able to embolize it, and they said it was due to an iniquitous being right there, and they were afraid they would stroke the scab because the branch was right there coming up. So very vascular tumor. Now we have a conundrum about what we're going to do in terms of having this incredibly vascular thing that's unstable with a frail patient. And so we talked about what our options were. One would be going going open lateral and tying things off ourselves, looking at everything. Ultimately, I gave this guy the option of us going posterior first and getting him stabilized. My thought is that at minimum, he's going to be able to transfer and stand and do things like this, and then we can always come back. In fact, we planned it as 2 stages to come back and then do a cage in the front. But we did the posterior part, which you see here, and he loved it, and he got up and was ambulating, left the hospital, and just basically didn't want any more surgery, and did well after that for several months. But and then went on hospice, and so he was a fragile guy. And I certainly think this was probably the right call, even though none of us loved it because he didn't have much bone in the front here. But certainly got him to a point that he could ambulate and get some relief. Patients can be tricky, obviously. So 58-year-old gentleman with intractable neck pain. Many of you have dealt with patients with these lytic lesions in their upper cervical spine. They can be incredibly painful. Sometimes they'll even just hold their head. And had metastatic lung cancer. And we had him planned for a surgery to stabilize this and get postoperative radiation. And unfortunately, we did stabilize him. In this case, we stabilized him to his occiput. Some people might say, well, why not go to C1? C1 looks free of disease. And as we go through this story, this will probably help explain some of that thinking, I think. And he never went to radiation. And it wasn't that anyone forgot about him. He kind of felt good, and I believe he took off on his motorcycle and said he just wanted to kind of be away, and knew he needed radiation, but just never went to his radiation. And so comes back, and what you're seeing here is a series of imaging as he comes back after not getting treatment, and his bone just gets eaten away more and more to where his on that right one, I believe his lateral mass screws were starting to get loose. And so we did have to take him back and revise him and take him down lower. This is about, I mean, what a terrible shot to see no bone here. And we took him down to T2. And you can see here, he continued to follow up with kind of no bone in his neck. And he continued to smoke. He did get radiation. And as we talked about, what other options we might do here, he really wasn't interested in another surgical option. He understood that he had no bone there, and he had 2 rods, and he could be paralyzed, and he wanted to live with the rest of his days with his collar, and felt okay about that. And that's actually what we did. So in summary, primary disease, the goal is typically curative in nature. In metastatic disease, surgery is for nerve root or cord compression or stabilization. I put a picture of my son playing basketball here. He's a basketball fanatic right now, and he's in the driveway working on his game every day. But the days of us, going at it solo in the OR, I think are over, or working these patients up solo. It's certainly a team sport, and certainly has to be a multidisciplinary approach in order to take care of these patients. And so with that, I think we'll end there, and I'm happy to take any questions or comments.
A great talk, Matt. This is Alex from Switzerland. Matt, may I ask you, when you go for a vertebral tumor resection and you place a cage from posterior, you choose the left or the right side? Can you make a comment on the Adamkiewicz artery?
Yeah, I think I guess what I would say is typically it's going to be placed. Well, I guess 2 things. One is a lot of times we like when we send that we like to embolize a lot of these, and we like to, when we do that, see where Adamkiewicz is and not touch it. So that's one thing, I guess. If we can leave it, we leave it. The literature would say though that in a lot of these cases you can take it and these patients are okay. And so there's all sorts of things about how many routes you take, and how this is different certainly from cardiothoracic surgery. But, the number of things you can, the number of routes you can actually disturb and be okay. And so most of the literature would say in these cases you could take unilateral routes with Adamkiewicz if that happens, and be fine up to 3. But not 100% of the time. Some people would say, well, even some of the literature would even say bilaterally 2 is fine, 3 is probably okay, but not more than that. And there's a whole bunch of things, as people have done in terms of do you clamp first? Do you look at your monitoring data after X amount of time? I think a lot of that's proven to be not perfect. So I guess that's the answer. Is on the one hand, I've certainly done plenty of cases where we haven't necessarily placed a lot of weight on that. I think as I get older, it's nice to have that data from IR and to see it and say, okay, well, is there any way we can avoid it? And then sometimes, of course, like the cervical thoracic one I showed, sometimes the corridor is there because of what you had to take. I mean, that's different. It's higher thoracic, but we had to take T1 on that one side, and so it was already kind of providing us our corridor to get in there. What do you typically evaluate it before? Do you clamp root if you're taking several, or none of that?
No, I'm only doing metastatic spine tumors. I sent the primary ones to the centers around. So I remember very well when I was in the university hospital, we were always discussing how many, but I actually don't have the experience like you have. This was my last question. What is the amount of primary in percent and the metastatic spine cases in percent in your practice, so we can have a feeling what is in your center, in your hands,
Boy, that's a good
your
question.
experience.
Yeah, that's a good question. I should figure that out. I mean, I'm mostly tumor in general in my practice. I'm certainly doing tumor every week. You know, how many, we've done several primary tumors in the last 2 weeks. But we also do a lot of metastatic disease. So I'm not sure what the number is. I don't know that I could tell you percentage. I gotta think I do much more metastatic, but maybe it's not as much more as I think. Maybe it's probably more metastatic, but the bulk of my practice is tumor. Certainly operating on tumor every week. And it helps, I think, that we have, to your point about experience, I do think we have a model, for whatever reason, that maybe it's the Midwest, but I do think we have a model that's really nice for the patient in that sense, in the experience sense, and that, Camille and I share all these tumors, and so it could come through his clinic, could come through my clinic, it could come through Dr. O'Keefe or Dr. English, our ortho-oncology colleagues. And so I think it in that regard, it kind of doubles, triples our experience in terms of dealing with these, which I think is really nice. And it seems like every case we learn something, and we always talk about it afterwards, what we learned or what we think we could have changed. And so it's certainly a busy tumor place, that's for sure.
Thank you, Matt. This was awesome. So many comments in the chat box. I think when we look to the centers in the US, Matt, you're awesome. You're presenting awesome cases. Wonderful, wonderful. Thank you very much for this talk.
Well, I certainly am blessed by my teammates here. That's for sure. There's no doubt about that. Well, thank you, everybody, and I'm not sure what we have next week, or Alex, if you know.
I know, I don't know. We will get the notice on Twitter for sure.
Perfect. Okay. Well, thanks again, everybody.